to a new episode of EGVRS Retina Around the World. And today our guest is Dr. Nancy Holkamp. Dr. Nancy is previously a professor of clinical ophthalmology and visual science in Washington University, St. Louis in Missouri. And she's currently the director of Pepper's of Retina Services in Pepper's Vision Institute in Chesterfield, Missouri. Dr. Holkamp is actively involved in clinical research and have been principal investigator or sub-investigator for more than 38 clinical trials investigating therapies for age-related macular degeneration, retinal vascular occlusion, and diabetic retinopathy. Her efforts in research have resulted in 80 peer-reviewed publications, 22 books, and 125 speaking invitations, both nationally and internationally. She's a member of the major subspecialty societies, including the Retina Society and the Macular Society, and she is a member of major subspecialty societies and co-founder of Women in Retina. Dr. Holkamp has been on editorial board of the American Journal of Ophthalmology and currently serves as a reviewer for several ophthalmology journals, such as Archives of Ophthalmology and Retina. Nice to see you, Nancy. It's a pleasure to have you today on the EGVRS show.
Well, Sharif, it's great to see you, and I am very happy to be here. Thank you for having me.
I had the privilege to observe with Nancy in St. Louis and to observe her in her practice and research, and it was a real honor. Thank you.
You were a wonderful student, and we really enjoyed having you help us with the research as well, Sharif. So I remember those times very, very well and very fondly.
Thank you, Nancy. So without further ado, let's introduce our guest today. After the introduction, Nancy, can you tell us what influenced you to be an ophthalmologist?
Sure. So I went to medical school at the Johns Hopkins University in Baltimore, Maryland. And of course, there's a very famous eye institute there called the Wilmer Eye Institute. And at that time, I had a very good mentor. His name was Stuart Fine, and he took me under his wing and helped train me. And I did my very, very first research project with Stuart Fine, and it ended up being presented at the American Academy of Ophthalmology meeting. And as a medical student, that was a big deal. And Stuart Fine was actually a clinical trialist. So there's no surprise that now I consider myself a clinical trialist. He made it look like fun and very meaningful to influence the future of our profession, to bring new therapies to patients. So that's really where I got my start.
And how did you choose retina as a subspecialty?
Well, I spent time in Stuart Fine's office and in his clinic. And I remember the first time I was ever able to see the entire fundus through a 28 diopter lens. And it was amazing and it was beautiful. So I thought that I could do that for the rest of my life. And here I am more than 30 years later doing the same thing.
So tell me about your challenges during COVID. How was it difficult for you during the practice and during COVID and after COVID? Have things changed in your practice?
Well, you know, I think we all struggled with COVID, and I think we all faced many challenges. One of the things that I learned was that ophthalmologists were particularly at risk. So very early on in the pandemic, if you looked closely at what was happening in Wuhan, China, there were 4 different types of doctors that were dying. There were emergency room doctors, there were anesthesiologists, and there were ENT doctors, and that all made sense. But the 4th group was ophthalmologists. And when you think about what we do every day and how we work with our hands and our faces very close to other people's mouths and nose, it really put us at risk. So 3 weeks before the CDC recommended that all Americans wear masks, I insisted that everyone on my staff wear masks and all patients wear masks. And since that day, we have always worn masks. We still do. And I have never missed a day of seeing patients because, as you know, Sharif, if there are people who will go blind unless they see us. And so we never really shut our clinic down, but we did follow common sense recommendations like social distancing, wearing masks, and then everybody on my staff getting vaccinated as soon as it was possible. So I think that we did the best that we could, and I think we were still able to see patients, take care of patients, and also carry on our clinical research largely uninterrupted.
I'm glad that things are coming back to, a bit of normal now, and things are relaxing a bit regarding the all the restrictions and stuff. So yeah, hopefully things could be back to how it was before. So tell me more about your hobbies and how do you spend time about work? I know the answer, but the audience would love to know the answers.
Well, Sharif, I have 2 children, and they are so fun, and I do like to spend lots of time with them. And my son has graduated from college, and he works for an electronic medical record company called Epic. And my daughter is a freshman at the Johns Hopkins University. So she's in college where I went to medical school. So that's very exciting as well. And right now, Sharif, I don't know if people in Egypt are big basketball fans, but there's a huge basketball tournament going on in the United States, and I'm at the NCAA Final Four tournament watching the basketball games right now. So I'm a big sports fan. So, but it's always good to make time for family and fun and leisure. You can't work all the time.
Yeah, sure. So about the fun, which countries did you find influential or did you really like when you visited abroad during your visits?
Well, I've been privileged to speak all over the world. And of course, your father invited me to Alexandria, and that is very near and dear to my heart. I still can't believe how beautiful the Mediterranean Sea is. So I very much enjoyed Alexandria. I've had the opportunity to speak all over Europe. I've been on a speaking tour of Australia. And the thing that really stands out for me is that all around the world, we all do the same thing. We treat our patients with very high level vitreoretinal surgery. We use anti-VEGF agents, really the same. And I really have to compliment the organizations that help spread education, such as the Egyptian Vitreoretinal Society, the American Society of Retina Specialists, and the standard of care of retina is so high around the world, no matter where you are. I've been in South America speaking, I've been in India speaking, and it's just so nice to see that we're all doing the same thing, maybe slightly different, but how I do it is different from maybe someone who's also practicing in Missouri. So there are normal small differences, but overall, the level of care, expertise, how people are current in the practice of vitreoretinal surgery is really, really gratifying.
It's true. Yes, that's true. What's your favorite food?
Well, I like them all. I like them all, and I like new and interesting foods. But right now, I'm very, very keen on sushi with
Okay.
very, very fresh fish. And I've learned how to make sushi at home. And I have found that it is really fun, and it's a fun way to entertain people, is to prepare sushi for them. But I live in Missouri, which of course has no access to water. So we end up having to fly the fish in overnight, and it's a very special occasion when we do that.
So let's take a short break now, so we can start with the scientific content after we finish the main content here, and then we can return back later on. Everyone, and we will continue with our interview today with Nancy. Yeah.
Thank you, Sharif. Well, Sharif, I'd like to spend some time talking about the port delivery system with ranibizumab. I've been devoting a lot of my research time and my clinical research efforts on the port delivery system. In fact, I am in 5 of the national randomized clinical trials going on with the PDS in the United States right now. So what we see here is the port delivery system. When a patient looks straight ahead, nobody sees it. But when they look down in their nose, because this implant is placed through the pars plana in the supratemporal quadrant under the conjunctiva, you can see it if they look down at their nose and you lift up their upper lid. Also, you can see the device if they look up and supratemporally, you can see it in their eye. That third picture there shows the release control element that allows for diffusion of 100 milligrams per ml of a special formulation of ranibizumab. That's how the drug is released into the vitreous cavity. And the final panel shows you exactly how big it is. It holds 20 microliters of this 100 milligrams per ml of ranibizumab. So this device is placed in the operating room, but then the port is refilled every 6 months with a special in-office refill exchange procedure. So I will kind of share with you my experience. So I first started with the port delivery system in the phase 2 ladder trial for wet macular degeneration. And this phase 2 trial was a dose range trial. It was to find the optimal dose for proceeding with phase 3 clinical trials. And so 220 patients were randomized either to monthly ranibizumab injections or 3 different doses of ranibizumab inside the port. It was either 10 milligrams, 40 milligrams, or 100 milligrams per ml. And the primary endpoint was the time to the first refill. Like, when did the drug stop working and when did patients start to have recurrent disease activity? And what you'll see is that there was a dose relationship when we look at the probability of a patient receiving any refill. And on average, the time to refill for the PDS ranibizumab arm of 100 milligrams per ml was 15.8 months. That means patients got the PDS at baseline, but did not need a refill on average until 15.8 months. And in fact, 80% of patients in this highest dose arm went greater than or equal to 6 months without a refill. So it was really instructive to designing the phase 3 clinical trial that patients would have 6-month refills of the port delivery system. And when we look at the pharmacokinetics, we also see a dose relationship. And what's key is that there's continuous release of drug over time. So when we currently give monthly anti-VEGF injections with ranibizumab or any other drug, we have a pulsatile delivery where we have very high peaks and very low troughs. But what we see through this PK data is that the release of drug is very, very continuous and slowly declines over time. And in fact, in the 100 milligram per ml group, it released drug to a detectable level for as long as 16 months. So again, the Archway clinical trial was the phase 3 clinical trial that led to FDA approval of the port delivery system for wet macular degeneration. And I was privileged not only to be a part of this clinical trial, but also to be the first author on the manuscript that is now published regarding these clinical trial results. And in Archway, about 415 patients were randomized to either monthly ranibizumab injections or this port delivery system. And we know with the highest dose from the latter study, it was 100 milligrams per ml, which is 20 times the usual dose of ranibizumab in our injections. Now, AMD clinical trials now only have to go on for about 9 or 10 months. And so the primary endpoint was balanced between weeks 36 and 40, but it was a 2-year study at week 96. So an important part of the Archway trial is that the AMD patients are typical AMD patients. The median age was about 75. And one key aspect that I want you to note is the bottom row. The number of prior anti-VEGF injections for both groups prior to entry into the study was 5. So people had already been treated with 5 anti-VEGF injections on average, which means their vision was good. The median vision of entry into the study was 20/32. So this is not a rescue treatment. This is a maintenance treatment for patients with good vision. And the Archway study was going on through COVID, and there was very little impact on this trial because patients still came into the office if they were part of clinical trials. So here's the primary endpoint. And what we see is the mean change in best corrected visual acuity from baseline in ETDRS letters. And again, as a maintenance therapy, we're not expecting vision to improve. We're really expecting it to be maintained. And we see that the two lines are just right on top of each other. And now we have data through week 72. You'll notice at the beginning in the PDS arm, there's an expected transient post-surgical drop in vision. These patients had surgery. Their eye is red, the surgery requires stitches, and so this is normal. And now that I do more PDS surgery in my wet macular degeneration patients, I tell them that for a month or so, their vision will actually be more blurred, but that it generally recovers by the 2nd or 3rd month. And now we also see that with continuous delivery of the port delivery system with refill exchanges every 6 months, it's equivalent to controlling the retinal thickness compared to monthly ranibizumab injections. And over the last 15 years of the anti-VEGF era, monthly ranibizumab injections has been the gold standard. Nothing has been better than that. And we see that this is, in fact, equivalent and non-inferior to monthly ranibizumab injections. So let's talk about doing the supplemental refills. Well, supplemental injections between the refill exchange procedures. You know, if we put in a port delivery system and we say it doesn't need to be refilled for 6 months, how often is that going to be true? Well, as it turns out, it's true for over 95% of patients. We have data on refill exchange interval number 1, which is that first 6 months. And we have data now on refill exchange interval number 2, which is the second 6 months. And about 95% of patients did not need refill exchange procedures. And although it's not shown here on this slide, the latest data shows that through refill exchange intervals 3 and 4, again, greater than 95% of patients didn't need any supplemental ranibizumab injections. So when you look at follow-up through about 78 weeks, we see that there's a 5-fold decrease in the number of treatments that people need if they have a port delivery system with ranibizumab in their eye. You know, through 78 weeks, patients were needing on average about 19.5 ranibizumab injections, But with the same result, a patient could have a PDS with just 4 treatments, including the implant, followed by 3 refill exchange procedures. Now, with the port delivery system, we are introducing a surgery into the management of wet macular degeneration. And so we're going to have some new adverse events. And these are called ocular adverse events of special interest because they're new. We didn't see them really with intravitreal ranibizumab injections. And I just kind of want to go over some of those adverse events. So the first point here is that most of them are occurring within the first 40 weeks or 9 months. And they're related to the surgical procedure. And we're going to show some videos of the surgery, hopefully, at the end of this. So that's the first point, that most of the adverse events are related to surgery and occur early. The second is that in this age group, most of the adverse events are a numerical increase in cataract, and not from trauma from the device and not really from the surgery, but there is a numerical increase. The second most common adverse events were due to conjunctival issues related to the surgery, whether it's a conjunctival bleb filtering leak, meaning that some fluid is emanating from around the device and getting under the bleb, kind of like a glaucoma filtering procedure. Or if you don't use the conjunctiva tenons to cover the implant, you can have conjunctival erosions or retractions. All of these adverse events can be addressed with improved surgical technique. There was, however, 4 cases of endophthalmitis. One patient lost vision because they were cleaning out a septic tank and they got Enterococcus faecalis, which of course is a very virulent bacteria. One other patient probably had an HLA-B27 associated uveitis and not true endophthalmitis in this study because they had recurrent episodes and similar episodes in the fellow eye, and the cultures were negative in that patient. But endophthalmitis is a concern, and it was identified by the phase 3 clinical trial. But as we know, endophthalmitis can also occur with injections. There were other adverse events too. One is called one was rhegmatogenous detachment. And interestingly, in these 2 patients, they were repaired without removing the implant. The vitreous hemorrhage was minimal and self-resolving. And occasionally, in fact, in 3 patients, the implant became dislocated, but it's another adverse event that can be improved with more meticulous surgery. So just in summary, from the Archway clinical trial, we learned that the port delivery system refilled every 24 weeks, which is about 6 months, could control both vision and disease in a way that was non-inferior and equivalent to monthly ranibizumab. And in fact, it did so over a period of 78 weeks with 5-fold fewer treatments. So patients could conceivably come to the office less. And although we identified some adverse events of special interest, I truly believe that that adverse event rate can be mitigated and that rate can be lowered with improvements to the surgical technique. And just in a few minutes, I'd like to undergo some of the surgical pearls because, as I mentioned, for the first time, we will be introducing a surgery to the management of wet macular degeneration. And in this surgery, there are 7 steps to performing the surgery. And the first is creating a large peritomy for good exposure. And you may even want to use a traction suture. And then you have to use generous undermining of both the conjunctiva and tenons. And in the US, retina specialists don't do much glaucoma surgery. I know that it's different elsewhere in the world, but we all have to be our best glaucoma specialists when handling the conjunctiva and the tenons. The other thing is to prepare the implant so that it's full of drug and there aren't air bubbles in the port delivery system. When doing the surgery, it's very important to have good hemostasis so that when we put the implant into the eye, we're not dragging blood into the eye. We need to place the implant away from the conjunctival relaxing incision. We make a cut down in sclera that's 3.5 millimeters in length. If it's too long, we will get implant dislocations. It's important to cauterize the choroid with extensive laser to the pars plana. In this 3.5 millimeter incision, you may be putting in as much as 75 to 100 laser spots so that when you go in with a 3.2 millimeter keratome blade, you don't get any bleeding or vitreous hemorrhage. Then you place the implant, and then there's very careful closure of the conjunctiva and T-nods. And so I'd like to show a video, and I hope that it's coming through. This is a video compliments of my good friend and colleague, Dr. Arshad Kanani, who has done a lot of these. You see the 6 millimeter conjunctival and T-nods opening. Here he's filling the port delivery system implant with drug. He's doing it under the microscope. So he's sure to make sure there are no air bubbles. And then he'll turn it over to make sure that looking at both sides, there are no air bubbles. Here's good hemostasis. We have very good exposure of this quadrant, even without a relaxing incision. We're going to mark the surface of the eye 4 millimeters posterior to the limbus, and then the incision is made 3.5 millimeters in length with a very sharp MVR blade. And it's mandatory you use a sharp MVR blade because you have to square off the incisions. And you're cutting down to the pars plana without perforating the pars plana. And you're separating all the scleral fibers. And we're very careful not to distort the wound or delaminate any of those scleral fibers. So we won't really spend much time grasping the lip of the incision. And we make sure that it is perfectly 3.5 millimeters in length. So that looks very good. Now we're going to apply that laser photocoagulation of the pars plana. It's not a step we usually do, and yet it's so important to decreasing the rate of vitreous hemorrhage when this blade goes through the pars plana. You'll also notice that this laser has a very long duration. It's 1,000 milliseconds or a full spot of laser. And you don't paint, you overlap the spots onto the pars plana until you reach an endpoint where the pars plana is really almost charred, and there's some percolation of vitreous fluid. Now we measure with a fixed gauge that's 3.5 millimeters in length to show that it's the perfect length. Now we go straight in and out with this 3.2 millimeter keratome blade, careful not to nick either side. There may be a little bit of vitreous prolapse that can be dealt with later. And then the implant is self-retaining thanks to the shape of a bullet. And you close the delivery forceps and tap it in place. And now, after cleaning up the vitreous around the implant with a vitrector, not a Wexel sponge or scissors, you draw up both the conjunctiva and T-nods. Take a scleral bite at the apex and close the incision. So important to have the T-nods also covering the device so that we don't get exposure. And it's very important to take a scleral bite and make sure that the in that apex suture that it doesn't retract. And here we're also closing the radial incision, and we'll also put a second suture at the limbus at the other side, just to make sure that it's nice and snug up at the limbus. So it's a beautiful case of putting in this implant. The patients will be on post-surgical eye drops. And again, they may have a transient decrease in vision because every patient after surgery does. Now that's the surgery, and I'm just going to show a very quick video of the refill exchange procedure, which also has some pearls. It's done in the office. Patients are usually recommended to lie flat. Very important to use magnification. I use surgical loupes when I do this. You can just use topical anesthesia drops like topical Alkane, because the needle isn't going into the patient's eye. They don't feel anything. It's going into the implant, into the port. And you, however, have to thread this needle for the refill exchange procedure into the center of the implant. And it's a full volume exchange procedure. 20 microliters of old fluid is coming out and 20 microliters of new fluid is going in. So here, hopefully we can get the video to run. There we go. Okay. I'm not sure let's see, maybe I can get it. There we go. So you draw up, this is again, that specially formulated 100 milligram per ml of drug. And you put on a special needle that will be supplied to you. That is a refill exchange procedure. It has a reservoir for holding the old drug as it puts the new drug in the eye. And there's the implant. The patient is looking down to their nose. The needle is oriented perpendicular to the implant phalange till it cannulates that septum. And now you're going to see fluid come up into the reservoir as the plunger is depressed. And then with counter traction, the needle is removed. So that's been my experience with the port delivery system. I really want to thank you for asking me to be on the EGVRS video series to talk about it. And Sharif, I'll just hand it back to you.
It's been a pleasure to hear from you about that, really, Nancy. It's new technology that I think would affect a lot of patients, especially after COVID time, where patient access was very difficult for hospitals. I'm talking about the UK, which was very difficult for some patients to come to hospitals during the pandemic. And we try as much as we can to try to defer treatment if there's a treat and extend option for some of the patients. But that can actually make the visits less frequent for a lot of the patients. How did you find that in your practice? Does actually the patient needs to come very often after having the implant?
Well, that's a really good question, Sharif, because, in a clinical trial, everybody has to come back to be monitored. So we never proved that we would decrease the treatment burden. Because they were in a clinical trial, they had to come back to be monitored. Yes. So it remains to be seen in the real world. And in fact, there are real world studies going on. And I am participating in those real world studies. But so far, since we have FDA approval in the United States, I have put in the PDS, and I saw my patients for their 1 day, 1 week, and 1 month post-op visit. And now I'm just going to see them, less frequently, because I know 95% of the time they'll do well without any other injections. So it's nice to have that confidence, and it is nice that patients don't have to come in that often.
Definitely. And technically, the surgery, have you found it, as a start, was it technically very difficult when you start doing it for the first time? To just, had to excise the tissues and go through the sclera, and about the bleeding and hemostasis, was it difficult in some of the patients to try to stop the bleeding?
Well, I can say that although some of the steps are new for us, they're surgical steps that are within the skill set of every vitreoretinal surgeon. The key is attention to detail, how meticulous each step has to be done. It's like cataract surgery. The first step has to be successful so the next step goes well. And that step has to be successful so the next step goes well. So it's very, very similar to the precision and the meticulousness that's required for cataract surgery or any of the surgeries that we all do. But I think there's a learning curve, but it can be mastered by everyone who is an eye surgeon.
And my last question, how would you know when you're doing the refills that you're inside that reservoir or the port delivery system?
Well, that's a great question too, because it can be very challenging to cannulate that port, and you really have to be perpendicular. And what's nice is if you're in the right spot, it kind of slides in. So if you're struggling to get the right spot, just pull away, regroup, and try again. It fits in nicely if you're in the right spot. But as soon as you depress with the plunger, if you see fluid come back, you know you're in the right spot. That's the only way that you'll get that flash of fluid in the reservoir. But it is a technique that is new, and it also has a learning curve to it.
Thank you very much for showing us that new technology, and I'm sure a lot of people haven't really had any experience. Even I think in the UK, there's no centers that have started with the PDS yet. I'm not sure if there's any actually, but it's a good to have that new technology, which actually can make a difference for the patient's care at the end.
Well, I'll tell you that there are now large clinical trials going on outside the United States, and I spend a lot of my time on Zoom actually training new surgeons how to do this procedure. There's something called pre-case training. But in this clinical trial, everybody will get a person called a surgical device liaison in the operating room for their first cases in this study. So, we are learning something new is exciting. It's what made being a vitreoretinal surgeon so fun for the last 30 years. But for people doing this for the first time, I'm sure that they will have adequate preparation.
It's a pleasure to have you, Nancy, and it's very nice to see you. It's always nice to see you on meetings or in person. Hope the meetings come back and we can meet in person again. Thank you for joining us today, and it was really a pleasure and an honor to have you on the EGVRS.
Well, Sharif, it's great to see you again, and thank you so much for having me on this program today.
Thank you.